Welcome back, everyone. Today we are diving into one of the most classic doorway presentations in clinical neurology and orthopedics, Wristdrop. Dr. Sarah, I'm fired up because this isn't just a physical finding, it's a total functional disaster for the patient. If you can't extend that wrist, you're basically working with a hand that's half retired.
Exactly, Dr. Khan. And for our students listening, this is a high-yield favorite for board exams because it tests your knowledge of the brachial plexus, humerus anatomy, and the relationship between muscle compartments. We are talking specifically about a lesion of the radial nerve.
The radial nerve, I like to call it the great extensor. It's the nerve that allows you to say stop with your hand or reach out for a cup of coffee. When it goes dark, gravity takes over. But before we get to the why, Sarah, give us the academic blueprint. Where does this nerve even come from?
High-yield fact number 1. The radial nerve is the largest branch of the posterior cord of the brachial plexus. It carries fibers from C5 all the way to T1. Its journey is what makes it so vulnerable. It exits the axilla, travels into the posterior compartment of the arm, and then, this is the big one for exams, it wraps directly around the mid-shaft of the humerus in the radial groove, also known as the spiral groove.
And that spiral groove is a danger zone. Think of the radial nerve like a traveler taking a shortcut through a narrow alleyway. If the walls of that alleyway, the humerus, break, the traveler gets crushed. Why does this matter clinically? Because if you see a patient with a mid-shaft humerus fracture, your first thought shouldn't just be, is the bone broken? It should be, is the hand dropping?
Precisely. If the nerve is damaged at the midshaft, we lose all the muscles in the posterior compartment of the forearm. These are your wrist extensors, your finger extensors, and the abductor pollicis longus. The result? The wrist hangs in a flexed position. The patient literally cannot lift the back of their hand toward the ceiling.
But here is the puzzle, Sarah. If the radial nerve is the great extensor, why is the patient's grip so weak? The muscles that make a fist, the flexors, are mostly handled by the median and ulnar nerves. Those nerves are perfectly fine, so why can't they squeeze my hand?
That is a brilliant clinical distinction. It comes down to what we call the length-tension relationship, or the tenodesis effect. To have a powerful grip, your wrist must be slightly extended. This keeps the long flexor tendons at the optimal tension to pull the fingers into the palm. When the wrist is flopped forward in wrist drop, those flexor tendons are already slack. They've reached their limit of contraction before the fist is even closed.
It's like trying to jump when your knees are already fully bent. You've got no leverage. I tell my students to try this. Flex your wrist as hard as you can toward your forearm, and then try to make a tight fist. You can't do it. That is what these patients live with every second. It's not just that they can't extend, it's that they can't effectively use what they can flex.
And that is why the doctor of choice for these patients is often a multidisciplinary team involving a great hand therapist who can provide a cock-up splint. By manually holding the wrist in extension, you actually restore the patient's ability to use their median and ulnar innervated flexors.
That splint is a game changer. Now, Sarah, let's talk about the Saturday night variety. Boards love this scenario. A patient falls asleep with their arm draped over a park bench or a chair after a few too many drinks. What's happening there?
That's Saturday night palsy. It's a compression injury in the axilla or upper arm. The key differentiator for the boards is often the triceps. If the lesion is high enough, like from a badly fitted crutch palsy, you might even lose elbow extension. But if it's lower, in the spiral groove, the triceps branches have already left the nerve, so elbow extension remains intact, but the wrist still drops.
Okay, so if I'm at the bedside, I'm testing elbow extension, then wrist extension, then finger extension of the MP joints. But wait, I've seen patients with wrist drop who can still straighten their fingers at the tips. How is that possible? Is the radial nerve partially working?
Great catch. This is a classic trap. The radial nerve extends the metacarpal phalangeal, or MP joints, but the interphalangeal, IP joints, are actually extended by the lumbricals and interossei. And who innervates those? The median and ulnar nerves. So a patient with a total radial nerve blowout can't lift their hand at the wrist or straighten their knuckles. But if you hold their hand flat, they can still wiggle the tips of their fingers into extension.
Why does this matter clinically? Because if you don't know that, you might falsely assume the radial nerve is recovering. You have to isolate the movement. Ask them to hitchhike with the thumb or point to the ceiling with the knuckles.
Let's round it out with sensation. The radial nerve isn't just motor. If I suspect a radial nerve injury, where should I be poking my needle to test for sensory loss?
The anatomical snuff box, that little triangle at the base of the thumb. The superficial branch of the radial nerve handles the skin on the lateral part of the dorsum of the hand. It's usually a very small, reliable area of sensory loss. It's not as devastating as the motor loss, but it's a vital clue. Perfect. So let's summarize the high-yield takeaways. 1. The radial nerve is the posterior cord, C5 to T1. 2. It is most commonly injured in the spiral groove of the humerus. 3. Wrist drop occurs because of the loss of the extensor compartment, leading to a secondary loss of grip strength due to improper tendon tension. And 4. Always check the triceps to see how high the lesion is. And my clinical pearl, don't just treat the nerve, treat the function. A simple splint that puts the wrist back in its power position can give a patient their hand back while that nerve takes its long, slow walk toward recovery. Great session, Sarah. Thanks, Dr. Khan. See you all next time.